In the last 60 years, there's been an enormous investment, it must be amounting to trillions of pounds and tax dollars, into understanding the biology of human disease. And the frustration that clinicians felt, and must have been shared by patients until very recently, was that although these fundamental advances in understanding of leukemia biology had been made, in acute myeloid leukemia it was difficult to see, apart from refining prognostication, how they were impacting on patient treatment. So from a patient perspective, the really exciting thing about this meeting is that we really are now making that bench-to-bedside translation. And there is a wave of new targeted therapies, different formulations of standard chemotherapy, and improved strategies around stem cell transplantation that are already impacting on patient outcome and are likely to become embedded into improvements in standard of care. So if I was a patient, I would be very interested in ensuring that the latest molecular strategies were being applied in terms of prognostication of my disease, and we're now routinely integrating mutational status of at least 3 genes, NPM1, FLT3 and CBP alpha, and it's likely in the next few months that using next generation sequencing, panels of up to 25 genes will be informing risk stratification, in addition to standard methodologies such as cytogenetics, presentation white count, and whether it was a secondary disease. I'd also be very interested in having the opportunity to participate in clinical trials, which will be so important in assessing the role of these new therapies and represent the bridge to changing for the better standard chemotherapy. I would also be interested in discussion with my clinician if they felt that I was eligible to receive intensive chemotherapy, whether they felt that a stem cell transplant using a sibling or unrelated donor was likely to be a benefit. It's a complex decision, but it's one that needs to be thought of very early in the treatment pathway. And were I to be a somewhat older patient for whom intensive chemotherapy was deemed to be probably too toxic, then I'd want to be thinking about accessing some of the new hypermethylating agents or azacitidine or other novel agents that are becoming of real interest. And that means, I think, supporting the infrastructure that's required to deliver prospective trials, and also recognizing that there aren't trials at the moment available for all patients, but that we should be moving towards an expanded portfolio of studies so that patients have access to these novel agents or can participate in their formal prospective evaluation as quickly as possible.